The following podcast is part of a certified educational activity titled Elevating NMIBC Care, Putting the Latest Innovations for Intravesical Therapies into Practice. Access the entire activity and complete the post-test at peerview.com/ARY860. Downloadable slides and practice aids are also available.
Hello, I'm Sia Danishman. I'm professor of urology and medical oncology and director of urologic oncology at the USC Norris Comprehensive Cancer Center. Welcome to this educational activity entitled Elevating Non-Muscle Invasive Bladder Cancer, Putting the Latest Innovation for Intravesical Therapies into Practice. I'll be discussing the latest therapeutic data, practical tips for treating patients with non-muscle invasive bladder cancer, and highlighting some of the exciting updates from the recent SUO annual meeting in Phoenix just a couple of weeks ago. So the goals of therapy for today during this presentation, we're going to discuss clinical evidence that supports modern intravesical treatments for high-risk non-muscle invasive bladder cancer. The use of intravesical therapies for patients with non-muscle invasive bladder cancer can be personalized according to patient preferences and the goals of therapy. And the care teams can formulate collaborative strategies to proactively educate the patients on non-muscle invasive bladder cancer, the treatment options, and support shared decision-making, effectively mitigate and manage the treatment-related adverse events that occur with treatments. So there are unmet needs in bladder cancer. Non-muscle invasive bladder cancer comprises 75% of newly diagnosed bladder cancer, and this has significant clinical challenges because of the high risk of progression and recurrence. And despite the fact that BCG has been used for many, many decades and is highly effective, up to 40% of patients will eventually fail BCG and require alternative therapies. Traditionally, radical cystectomy has been the standard of care for BCG-unresponsive disease. It can significantly alter the quality of life of the patients, and it can have significant morbidity and even mortality associated with the surgery. The development of effective, safe, and durable intravesical treatment remains a critical unmet need for patients who want to avoid radical cystectomy or are unfit for radical cystectomy. The importance of effective patient identification to support the use of these novel intravesical therapies is paramount. We need to identify what the disease state is, make sure we know what the prior treatments have been. Carcinoma in situ is something we talk about all the time with patients. It's difficult to understand that these are high-grade cancer cells that are on the surface layer of the bladder, but have the biologic potential to penetrate deeper and form invasive diseases and even metastasize. So it is a very important disease state, and one in which many of the drugs are approved in this state, having CIS that is unresponsive to BCG. And of course, you have the different stages of the disease. Non-muscle invasive bladder cancer comprises high-grade TA, T1, and CIS, whereas muscle invasive bladder cancer would be anything T2 and higher. So here are some of the FDA-approved treatment approaches to high-risk non-muscle invasive bladder cancer that's unresponsive to BCG. In December of 2022, after many years of not having other approved therapies, we got the viral gene transfer of mataferigine feridenavac approved in December of 2022, and in early 23, it was in commercial use. And this is, again, for the treatment of patients with CIS with or without papillary disease. The IL-15 superagonist nogapendecan inbakicept was approved in April 2024. This is an IL-15 superagonist and is used with BCG and is approved in the same setting. And then, so these are intravesical therapies, and then we have this novel sustained release of gemcitabine with the Gem-iDRS system, the intravesical drug releasing system, previously known as TAR-200 in the clinical trials. This was just approved in September 2025, again, for the same thing, CIS with or without papillary tumors. So we now have the emergence of 3 novel treatments. Before that, we also had Keytruda or pembrolizumab for the same disease state, but that's a systemic disease that's in the IV form. And before that, we had valrubicin, which is hardly ever used today because of its very low long-term efficacy point. Of course, we do have non-FDA approved therapies as well, combination chemotherapy like gemcitabine and docetaxel given together sequentially in the same day, same regimen as we do for BCG, and that has been very effective as well. So we do have a number of options now available to us. Let's go back and talk about gene therapy for non-muscle invasive bladder cancer. Again, this is nadofaragene firadenovec. This was the first gene therapy approved for non-muscle invasive bladder cancer. It's a non-replicating adenoviral vector-based gene therapy, delivers this human gene, that interferon alpha 2b DNA, into the urothelial cells. And what it does, it enhances viral transduction to the urothelium using SYN3. And this is the gene is transcribed into the interferon alpha 2b protein in the bladder epithelial cells, not necessarily the tumor cells, the actual bladder cells. And it exhibits both direct and indirect immunomodulatory effects inhibiting tumor growth. So the approval was based on a phase 3 single-arm trial of nadofaragene firadenovec monotherapy in high-risk non-muscle invasive bladder cancer that was refractory to BCG. 53% of the patients with CIS, with or without papillary disease, had a CR within the first dose of this treatment. And now we have 5-year follow-up for this treatment on the same patients on that trial. And you can see that a number of patients are having recurrences. However, of the patients who had the response, there were 5 patients who had ongoing responses at the last follow-up. And again, the follow-up exceeded up 5 years. There were 9 additional patients who discontinued treatment and had ongoing responses at the last assessment. So we have 14 patients who at last follow-up or at 5 years had ongoing responses. So this is important, obviously, for the patients who are responding, but we have a lot of patients who do recur. They recur early on. You can see that in the orange lines there. So there are a number of ongoing studies. This drug continues to be developed in further studies. There's a very exciting ABLE-22 study. It's a phase 2 nadofaragene firadenovec alone or in combination with chemotherapy or immunotherapy in high-risk BCG unresponsive non-muscle invasive bladder cancer. So it's a 3-arm trial, randomized 2 to 1. The one would be the nadofaragene plus pembrolizumab. So seeing whether combination therapy will actually enhance the therapeutic responses. Also in this trial, importantly, reinduction is allowed for patients who have persistent disease at 3 months. That was not allowed in the pivotal trial. And so something we want to see whether a reinduction will help us get to complete response at the 6-month mark instead of the 3-month mark. There's an ABLE-32 study that's in intermediate risk non-muscle invasive bladder cancer. These are the recurrent low-grade cancers or small high-grade Ta tumors. So that's an ongoing global trial as well. The phase 4 ABLE-41 study is just a real-world use of Adstiladrin or nadofaragene. It's obviously been approved for some time, and we want to see what's going on around the world in terms of where it's being used, what its experience is, both for the patients as well as the providers, and get a sense of what the real-world sort of outcomes are, clinical outcomes. This is basically a superagonist antibody cytokine fusion protein that enters the cells and leads to this immunogenic response. So it's given with BCG. So nugapendekin with BCG, again, the same patient population, the BCG unresponsive non-muscle invasive bladder cancer. This was the phase 2/3 QUILT study. There were 2 cohorts. The first cohort was the one we've been talking about the whole time, CIS, with or without papillary disease. The complete response rate was 71%, and this was maintained in half the patients after 45 months of follow-up. That's really significant. So we're seeing good responses and durable responses. The 36-month cystectomy-free rate among the responders was 84%. So that's also, again, encouraging to see. In cohort B, this was papillary-only disease. The 36-month cystectomy-free rate was 82%, and disease-specific survival was 96%, 3-year results. So excellent results seen here for both the CIS population as well as the papillary-only population. So next is the Gem-iDRS, the intravesical drug delivery system for non-muscle invasive bladder cancer. This is a novel mechanism of delivery of medication into the bladder. This enables the sustained delivery of gemcitabine through all the layers of the bladder wall, increasing the dwell time and local drug concentration, as opposed to placing it in the bladder just for an hour at a time. This is placed in the bladder through a special catheter or an inserter. It's very similar to a catheter. Once it's released into the bladder, it curls into this pretzel-like shape via a small wire that maintains its shape. It basically floats around the bladder, is not sitting in one place, is very well tolerated by the patients, with most of the AEs being grade 1 and grade 2, very few grade 3 AEs. The patient doesn't really feel this. Again, it's floating in the bladder with the urine in the bladder, and there are no limitations to patient activities. There may be some dysuria or burning in some patients. Usually that goes away with time, and we can alkalinize the urine and increase hydration and things like that too for better tolerability. But again, the grade 1 and grade 2 was seen in a few patients and very, very few grade 3 AEs. Okay, so this was just presented at the SUO. This is the healthcare provider experience with the Gem-iDRS and non-muscle invasive bladder cancer. The healthcare providers and APPs, which I mentioned can place and remove this device, thought this was very straightforward. Majority of them took less than 5 minutes, could be performed in various non-surgical settings in the clinic. It doesn't have to be a cystoscopy suite, for instance, for that first insertion, and a removal and reinsertion is a relatively easy process. In women, it's potentially even easier. Very few of the cases were complex, and removal again and subsequent insertions were often performed during the same visits, and it was found to be easy to store and manage in practice. In terms of adverse event management, lidocaine jelly is always used in insertion. The video instructions are available and are useful for healthcare providers who haven't placed this before. But again, I think most healthcare providers, urologists, and APPs are very accustomed to placing catheters, removing catheters, and placing these devices with stylets and pusher devices. So many of the healthcare providers consider the Gem-iDRS system to be better tolerated with local and mild AEs and less time consuming compared to other intravesical therapies. Again, we're very used to having significant side effects with BCG and chemotherapy as well. So we're very used to hearing about the urinary frequency, urgency, things like that. And over half the healthcare providers reported anticipating insertion removal can be transitioned to APPs. Again, very important in busy practices where many APPs are handling the non-muscle invasive bladder cancer management with intravesical therapy. So again, half of them thought that they could transition the ongoing treatment for patients over to their APPs. So these were participants and urologists from both academic and community practices across 13 states. So pretty representative of the practices in the U.S. So the approval for the Gem-iDRS based on this Sunrise 1 study in the BCG unresponsive high-risk non-muscle invasive bladder cancer cohort. There were 3 cohorts. This was tried with citrilimab, which is a PD-1 inhibitor, alone or in combination therapy. But the approval was really based on cohort 2, which was the monotherapy in 85 patients. The dosing was once every 3 weeks. So we placed the device, and then it's exchanged at 3 weeks, meaning we remove the old device, place a new one in. And this cycle continues for six times up until week 24. After that, it's quarterly placement and replacement up until week 96. And the primary endpoint was overall CR rate with secondary endpoints of duration of response, overall survival, safety, and tolerability. There was a 4th cohort with monotherapy for papillary disease only. So no CIS, and that was recently presented. I'll get to that a little bit later. There were 52 patients with a primary endpoint there being disease-free survival because there's no CIS there, and so we're not looking for complete response rates. So when you look at the cohort 2, this is the one that got the FDA approval. There was the complete response rates, again, CIS cohort with or without papillary disease, 82%. And the duration of response was at 12 months was about 52%. So most of the patients are responding, and most of the patients are sustaining that response at least for 1 year. So when you look at recurrence and progression with the Gem-iDRS monotherapy in patients with CIS with or without papillary disease, the estimated 12-month and 24-month cystectomy-free rates were 86 and 75%. So for the most part, patients are retaining their bladder and doing quite well. There were very few progression events. When you look at the papillary disease only, so cohort 4, which we just described, they're also doing very well. This was just presented at the SUO, the Society of Urologic Oncology meeting in Phoenix. And 74% of the patients at 1 year were disease-free. And several patients were out to 18 months, and it's still around the 70% range. Importantly, in this cohort, 40% of the patients had T1 disease, and when you split it between the TA and T1, the responses were the same, about 75% for each one. So the 12-month progression-free survival and overall survival is also excellent, in the high 90s for overall survival. Only one patient out of the 52 ended up progressing to muscle-invasive bladder cancer, a very important point, and when you're trying novel therapies for non-muscle invasive bladder cancer. In time to cystectomy, again, very few patients underwent cystectomy. Only 4 of the 52 patients, or 7% of them, ended up having cystectomy. Again, this is for papillary disease only. So there are a number of other ongoing trials with this intravesical delivery system. I think this is just a beginning. We have the phase 3 Sunrise 3 trial. This is in the BCG naive population, high-risk non-muscle invasive bladder cancer, 1,100 patients. This is a global worldwide study that accrued extremely well and actually finished accrual 1 year early. We don't have results yet, but we're very excited to see results. There were 3 groups. The first group was the Gem-iDRS system with citralumab. Again, that's a PD-1 checkpoint inhibitor. Group B was BCG, and Group 3 was Gem-iDRS. So we're going to see the individual components of the treatment responses here. The Sunrise 5 is a recurrent high-risk papillary only. It's very similar to that cohort 4 I showed you in Sunrise 1, but this is a randomized study. So randomized is a phase 3 randomized between the Gem-iDRS with the intravesical, either gemcitabine or mitomycin. Again, global trial, and comparing one of the very few phase 3 trials looking at a comparison of standard therapy in this disease state versus a novel therapy. There's some other ongoing settings for this delivery system. The Sunrise 4 was a phase 2 study looking at a neoadjuvant approach, basically in muscle-invasive bladder cancer patients. Smaller trial, 160 patients, global trial, doing gemcitabine, the drug-releasing system with citralumab, versus the citralumab alone as neoadjuvant therapy in patients who are cisplatin ineligible. And this has already been presented at multiple meetings. It has a fairly high path CR rate for citralumab monotherapy was 28%, with the combination therapy 38%. So we're definitely seeing some responses here with a combination therapy, and the 12-month recurrence-free survival rate so far is 77 versus 64%, supporting further investigation of some kind of combination therapy in muscle-invasive bladder cancer as well. So there are lots of exciting also developments in using other drugs in this. One of them is erdafitinib. The phase 3 Moonrise 1 study is in the intermediate risk non-muscle invasive bladder cancer, basically patients with recurrent low-grade tumors or larger size low-grade tumors or small high-grade Ta tumors in the intermediate risk patient population with FGFR3 alterations. 640 patients. The group, one group received TAR-210, which is erdafitinib, an FGFR3 inhibitor delivery system into the bladder, and Group B is getting the intravesical gemcitabine or mitomycin against standard of care for this. So exciting trial, lots of patients. We're going to have great data on this, and we already have excellent preliminary data on the efficacy of the TAR-210 device delivering erdafitinib into the bladder with the phase 1 studies. So the oncolytical adenoviruses are here now. Accreditation, Granada Repvec is another pretty exciting new development. This is an oncolytic vaccine, basically engineered to express GM-CSF, replicate selectively in tumor cells that have mutated or deficient RB pathway. And so this enters the cell, lyses the cell, and elicits the immunogenic response. And it's given very similarly to sort of a BCG regimen with an induction course and then a maintenance course. And reinduction is allowed for patients who have persistent disease at 3 months. So this is the BOND-3 study, one of the first studies done in this population. Again, high-risk BCG unresponsive non-muscle invasive bladder cancer. There's a cohort C, 112 patients. The CR rates were 75%. Very similar you're seeing to the other novel agents here. The 24-month landmark CR, 42%. So now we're raising the bar really to the duration of the response for these novel therapies. And I think, this is really spectacular response. And when you look at the cohort P, which is the papillary tumors that did not have any high-grade, CIS present, you can see the response rates are excellent and go out to a year. So this is just presented again at the SUO, the cohort P, with excellent response rates of in the 80% range for the papillary disease only. It's only 9-month follow-up, but still very exciting sort of novel results. So this is the Core 008 study. It's currently ongoing around the country. The cohort A is cretostimogene grenadenorepvec in patients with BCG unresponsive non-muscle invasive bladder cancer. The CR rates are very high, 84% so far. So safety considerations, all of these intravesical therapies have some adverse events associated with them. Again, most of them are grade 1 to 2 for all of these novel agents. There are things we're used to, the common local toxicities that we see with BCG, with chemotherapy. These include dysuria, urinary frequency, urgency, UTIs, and bladder spasms. And it's important to know how to manage these. We already use many of these medications in patients who've previously received BCG, but I guess there's now a little bit more focus and how can we prevent these adverse events from happening in the first time. Use of novel antispasmodics and pre-medicating some patients. Everybody has different practices, but it's good to know sort of what to use, get familiar with it, and try to reduce these AEs. Most of them quickly resolve. There are so far no long-term safety signals seen in any of these novel therapies that I discussed with you. So let's review a patient case. This is a 72-year-old woman with non-muscle invasive bladder cancer. Her ECOG status is 1, so not the healthiest patient. She has CIS with high-grade Ta disease, deemed to be BCG unresponsive after an induction course as well as a 3-week maintenance course, and has recurrent CIS and high-grade Ta within 1 year. Undergoes repeat TURBT. There's no residual tumor. She does have some comorbidities with diabetes, hypertension, and some weakness in her muscles, requiring the use of a cane. So, again, not the most robust patient. She has a relatively small bladder capacity, sometimes difficult for her to maintain some of the medications. Lives about 20 miles from the clinic, needs short clinic visits. She does rely on her working children for transportation. Very important sort of point to discuss with the patients because these are ongoing treatments back and forth. Her goal is bladder preservation, as is with many patients. So, we can talk about the FDA-approved intravesical options that are available to her. We discussed a number of these just now. We need to discuss dosing schedules and whether it makes sense for her to have one treatment versus another. Generally, what I do is discuss all the treatment options for the patients and see with their results that we know, the 1 year and the longer term, if available, and see which one appeals to the patient more or is more suitable for that patient. Is it intravesical drug delivery system for this patient or installation volume? Some of the drugs have larger installation volumes and are more difficult to retain. I mentioned she has a small bladder. So those are things to consider, with their prior therapies, how difficult was it to maintain the drug in their bladder? And then discussion with the family of how they're going to manage to bringing the patient back and forth for the various treatments. So all of these are what we tend to discuss with the patient and the care team. I always like to include the family members or friends or whoever their support group is in this discussion, because I think it's all very relevant. Now, there are patients who have papillary disease as well without CIS, and that's a whole other discussion. We talked about some of the therapies, but none of them are FDA approved yet in this patient population of papillary-only disease in terms of adjuvant therapy. So there's some discussion there as what would you use there if you didn't have any CIS. It only is a matter of time before these drugs get approved for papillary disease only. Obviously, they work in the same way. The mechanism of action, it should be no different. It is an adjuvant therapy versus an active therapy. So lots of different considerations here. So in summary, there are a lot of exciting advances for our patients with non-muscle invasive bladder cancer. I hope you found this educational event to be useful and informative in your practice. Please remember to submit your post-test and your evaluation for credit, and download the slides for practice aids. Thank you very much for joining.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Johnson & Johnson. To access all materials for this activity, visit peerview.com/ARY860.